syndrome, and also 50% of the cases is the known. So maybe I can change those names. It is only in the 50%. 50% does not explain all the autism disorder. So some parents get frustrated when you ask about genetic, to the study of genetic mutations, and you cannot find the answers. Okay, let's start with substance abuse. Is there any questions so far? I feel like I'm the only one talking here, and I feel like we're... No?
No questions.
No questions, okay. Okay, now changing subjects. We're going to start with substance abuse. So I told you, and you've seen in the vignette, that we have a lot of questions about substance abuse. I'm going to try to make sure that you understand two things that are very important. It's not the same pathophysiology when we have an acute substance abuse disorder and which is compulsion, addiction, versus when we have dependence, chronic abuse, okay? So with that being said, let's start with alcohol. Of course, alcohol is going to use and activate the GABA or gamma aminobutyric acid or GABA receptors. Is that the only receptor that alcohol uses? No. Also, it uses serotonin receptors. People feel great when they start drinking. They don't feel so great when they continue drinking. But at the beginning, they do feel good. Also, it inhibits the glutamate receptors. So alcohol is a big depressor of the central nervous system. It uses the GABA receptor. So I try to summarize here almost everything about acute and chronic alcohol abuse disorder. So knowing that alcohol binds strongly to the GABA receptors, it will start a cascade of sedation, cognitive dysfunction, and decrease in coordination in the patient that starts drinking. When the patient starts drinking acutely, the one receptor and neurotransmitter that's going to be using and taking place, it's going to be the GABA receptor, okay? After that patient already had fallen into addiction and continues drinking into a dependence, chronic drinking, what is going to happen to that person is that glutamate is going to take place. We said that glutamate transmission, it's going to be inhibited, but the receptors are going to be upregulated. If that person continues drinking, it will start having a big, huge dependence to alcohol, and it will develop what we call alcoholism, okay? An alcoholism problem. What happens if that person stops? It's going to develop an emergency problem called alcohol withdrawal. During alcohol withdrawal, the thing is that the patient already developed a lot of receptors called NMDAR receptors for glutamate. When that person stops drinking, glutamate, it's going to have a lot of receptors to join. And that person will have what we call hyperexcitability. The hyperexcitability is the one responsible for seizures and hallucinations and alcohol withdrawal. The only way to treat that is the use of benzodiazepine in order to displace the GABA receptor and inhibit the hyperexcitability due to excess of receptors of glutamate. So we're using benzodiazepine. It's a way of making that patient, okay, we're going to use the same receptor that you were using with ethanol to treat you, but not ethanol. In this case, we're using benzodiazepine. This is for an acute resolution of alcohol withdrawal. For chronic intake of alcohol, somebody asked me about that, is I think the only solution to take away a patient from alcohol dependence is Anonymous, Alcohol Anonymous, AA. It's a group session where they go and resolute 12 steps. And it's a kind of conductive behavior therapy, but in a group. And it's the only therapy that worldwide has been treating alcohol dependence, and it works. But it requires a great commitment from the patient to continue going to those groups. It's a long life treatment. Okay, so let's go here. The 4 syndromes associated with alcohol withdrawal, it's minor withdrawal, seizures, alcohol hallucinosis, and delirium tremens. Delirium tremens, it's the most complicated one, and it has almost all the symptoms that you already know. Okay. What is the most important vitamin you can give to a person with alcohol dependence, and why? So a person that has alcohol dependence and it has many years of drinking in his history, usually they tend not to intake balanced nutrients, and they become deficiency in vitamin B1. So they are going to be in very high risk factor of developing Wernicke and Korsakoff syndrome. Wernicke, we already talked about this, is mainly when you want to diagnose it, you suspect it, and you look for it by the discover that the patient has Gauss palsy or a nystagmus present. Also, a history of drinking for a long time. And Korsakoff is going to be a present following the Wernicke's encephalopathy. Okay. Somebody asked me, I think it was Laura, the main difference between Wernicke's and only a simple alcohol withdrawal is going to be the deficiency of B1. In alcohol withdrawal, you cannot necessarily have a deficiency of B1. You have different stages, by the way, of deficiency. Of alcohol withdrawal. Opioids. When we talk about the reward pathway of opioids, addictive problems for opioids are going to be very high due to that they use 3 different receptors in the analgesic opioids pathway. That also opioids, when you see here in color orange, green, and pink, receptors for analgesia are located from the brainstem up to the brain cortex, and also in the thalamus and the striatum. So they are located all around the central nervous system. But opioids not only are going to use the analgesic pathways, and those 3 different types of receptors, they are also going to use the dopamine pathways as a way of reward. So that's why opioids are very addictive. We have natural opioids that like codeine and morphine. I don't know if you remember that codeine was part of some of the medications that a long time ago they use on kids to stop coughing. They use codeine, and the problem is it's very addictive. So people that this occurred like in 1970s, 60s, then they took it off of the market, thank God, because a lot of people that drink that medication with codeine for cough during childhood, they keep doing that same thing because they were addicted to codeine. So codeine and morphine are natural opioids. We still use morphine after surgery. So make sure to know that morphine is addictive for your patient. And we also have semi-synthetic opioids like oxycodone, hydrocodone, and other methadone is also synthetic opioid. And the illicit opioid is heroin. Of course, there is a very, very stretch limit between or threshold between overdose and not overdose of heroin. So we have currently epidemic of opioid and heroin in the United States, and heroin can be in different presentations. There's something, we still have oxycodone, Vicodin, right, and Percocet. All of those opioid are the most used opioids. And I'm just mentioning this because it's important that you know which are the opioids. Highly, highly addictive. Let me just tell something. One of the big reasons of having epidemic of opioids in the United States is because of medical personnel. Anyone that works in healthcare, we need to make sure when to start and when to stop an opioid in a patient in order not to make that patient addictive, and try to do another resources maybe to lower the pain of that patient. Okay, cocaine, the way of action is just blocking the reuptake receptor of cocaine. So levels of cocaine are going to be very high and going to interact with the receptor in the postsynaptic neuron. And that will lead to a lot of symptoms. Cocaine, remember, apart from making hyperexcitability in the patient, are going to be cardiotoxic. They're going to be a potent vasoconstriction. So patients that are intaking cocaine can have hypertension, can have myocardial infarction, strokes. And also cocaine in pregnancy, it's going to elevate the increase of fetal mortality and mortality and lesions in the brain of the baby. Cocaine is directly cardiotoxic for the heart. It's cardiotoxic. There's a lot of pathology induced by cocaine. It has to do also with high frequency of lipid cord plaque in the carotid. It's vasoconstrictor, but it is aortic dilatation, hypertrophy of the left ventricle. It produces inflammation also in the endocardium and endothelium. I mean, cocaine has a lot of acute and also chronic mechanism. So if you want to choose maybe a substance, we don't use cocaine. Okay, cocaine is going to make you, it really kills people. So we have cocaine intoxication is, we know the effects. It causes euphoria. It also produces insomnia. one of the physiological effects that I told you about, apart from tachycardia, diaphoresis, tremor, is to look in the eye and look for dilatation. It's going to have psychiatric effects. So we need to look for and ask about cocaine in intake in patients if we're seeing a panic attack, anxiety, or mood disorder, paranoia, grandiosity. If we have a patient that we're suspecting schizophrenic or psychotic, we need to ask about, can this be a cocaine intoxication? Because that is one of the differential diagnoses. So cocaine also does problems chronically in our brain. It has to do with myelin integrity, and also it has to do with the decreased levels of neuromelanin in the ventral stratum. Ventral stratum has to do with the control of that person. It reduces in the ventral stratum the dopamine activity. So cocaine has a lot of effects. Okay, now let's make a difference between acute cocaine intake and chronic cocaine intake. Remember that when we talked about alcohol, we made a differentiation between acute and chronic. The same thing for cocaine. In acute cocaine intake, the two structures that are important are going to be the nucleus accumbens and the amygdala. Okay, so nucleus accumbens is going to have a role very important with dopamine-dependent reward circuits that will make the patient give the motivation to look for the drug. Okay, and the amygdala has to do with those emotions. I feel better. I remember that when I took that cocaine, I feel better, and that amygdala will help and keep the compulsion in the acute substance abuse of cocaine. What happens with chronic use of cocaine? We develop dependence. And which part of the brain is going to do a shift to turn me from an addicted person to a dependent person? Well, it has to do with the part of the brain that controls, and that is the striatum. It is called anterior dorsal lateral striatum. We have a lot of parts in the striatum. At least remember that is the striatum, the one that if a person continues exposing itself to cocaine intake, it will change from compulsion to dependence, meaning from addiction to dependence, and it will continue this stratum to change and shift that behavior in that person. Is there any question about this, or are we good? We're good? Okay.
We're good.
Okay, so amphetamines, we didn't talk a lot about amphetamines, but I don't know if we remember the Hollywood artist. What was her name? Oh my God. I forgot. She used it like the red shoes and click it on. Oz.
The Wizard of Oz.
The Wizard of Oz. The Wizard of Oz. You remember the girl that used like the red shoes and she clicked it in the Wizard of Oz? Okay. What was her name? Dorothy. Okay, no, but I was thinking about her real name, Dorothy. Remember her real name? Well, that girl.
G.P. Garland.
Oh, no. Okay, exactly. Okay, so she used amphetamines to keep herself in well shape, like not gaining weight. So amphetamines alters the transport of several amines, not only dopamine, also norepinephrine and serotonin, and is also addictive. So this is another substance abuse, not very common, maybe nowadays, but some people still remember that this artist used it to lose weight. So some of them, maybe some woman can use this. I'm just pointing out so you will know. So we need to make differential diagnosis for acute psychosis, right? And I think we did one of these questions. What was the etiology for acute psychosis, or which of these can cause psychosis? So abuse of amphetamines or cocaine, both can produce psychosis, okay? Withdrawal of alcohol produces psychosis, produces hallucinations. Intoxication with cannabis, there's a lot of use of cannabis right now. That doesn't produce psychosis, it produces paranoid, like delusions, okay? A little bit different. Abuse of ecstasies or LSD does produce psychosis. So acute psychosis, it's not only produced by schizophrenic disorder, it can be produced by substance abuse. Okay, based on the pathogenesis of alcohol addiction, this is a question. Which of the following explains benzodiazepines can be used for alcohol withdrawal? Well, this was one of the questions of the quiz. Alcohol and benzodiazepine both uses the GABA receptor. And of course, after we use the same receptor, we're going to have similar outcomes in the patient. Okay, this is another part, schizophrenia.